as you mentioned, I'm Jade. I am a board-certified neurologic clinical specialist physical therapist, which is a mouthful, but it's a physical therapist who specializes in neuro, meaning I've had advanced training and competency in working with patients who have neurologic abnormalities. So in full disclosure, have I ever treated some with Mowat-Wilson syndrome? Not that I know of. But then I found out that there are only about 117 in the US diagnosed, so maybe not. So I actually, when Al called, thought, well, you know, I have not actually seen this with my own two eyes, so I don't know that I'm the gal for the job. So I did a little research and realized this is just abnormal neurologic development. I have got this. I deal with this every day, all day. I just didn't know that this was a version of it. So I appreciate you guys letting me come to speak and also to learn more about this rare genetic disease process. And so thank you for having me, and there will be plenty of time for questions, and we'll get through this. How many of you are currently in physical therapy, or your children are in physical therapy, or have had? All right, so you're not new to PT. I will go through, from a neurologic standpoint, what your PT should be looking at, how they should be treating your child, and kind of go from there with then opening up questions, okay? There are identified strategic ways to work with the nervous system to make it get its optimal function, and we're going to talk about those today. So my two goals are really that you take home something that you can do with your kid that helps you to identify, okay, this is how I'm going to maximize function, and that you know what can a PT do and when should I be looking for PT. Okay? And I didn't give you my background yet, but I will quickly. I have been a physical therapist for over a decade. I started at the National Rehabilitation Hospital, primarily in inpatient rehab. After having children of my own, decided I need a little better work-life balance and left one job for 4 others in that now I still work there, PRN, and I work at another rehab hospital, but I primarily see patients, neurospecific patients, in an outpatient clinic in Falls Church, which is just about 15 minutes from here. I also teach at Marymount University in their doctoral program for physical therapy, teaching neuroscience and neurorehab, a little bit of acute care and geriatrics occasionally. And then for fun, I help to write the licensure exam for physical therapists. So that's kind of what I do. So I did that so I could have better work-life balance. I'm probably crazy, right? And I love neuro stuff, so I'm really excited to be here today, and neuro gets me excited, and you know, I'm sure you've heard that we know an nth of what the brain is capable of, so we're constantly learning, and so that might be why I was so excited to learn more about this today. All right, so common symptoms, I don't need to tell you guys, but in doing research, this is what comes out. Global developmental disability is present, okay? Meaning that these kids may not be able to sit, walk, or run at the appropriate times, if at ever. They may find that they scoot on their bottom instead of the reciprocal crawling that we're used to. This may be the child who has difficulty tolerating tummy time, which we hear all the time now, oh, the importance of tummy time. This is the kid that just doesn't do it. Fatigue with performance of gross motor skills, you may find in the morning or right after a nap, they can be really helpful with getting things done that need to happen. But then as they fatigue, the skill goes down and you're having to do more of the work and they're frustrated. Hypotonia. Hypotonia has been documented in 93% of the cases of Mowat-Wilson syndrome. And so that's one of those that, okay, hypotonia, PTs are all over that, right? So we got this. But these are the kids who, you know, when they're a baby, you pull them by the little fingers because they still have their grasp reflex, and you lift them up, and instead of them bringing their heads up, their head lags behind them. That's a big sign for, hey, something's up, we got to figure out what's going on here. These might be the floppy kids or the clumsy kids. As they age, these may be the kids that choose to be less active on the playground or with their peers. They're not going to be the ones that are up and running and climbing on the jungle gym, but maybe the kid that just sits, depending on the sensory processing issues, near the sandbox or completely away from it if the sensory processing disorder is there. Which is my next point. And then difficulty with motor planning, meaning even if they physically had the strength to do it, the brain isn't coming up with the plan to make it happen, okay? And then impaired balance and coordination. The next slide will have more symptoms. These are underlined because these are the ones that the physical therapist is directly acting on when they do treatment. So these are the ones that we are specifically improving. Other symptoms might be impaired intellectual abilities with learning, language, emotional expression. There could be epilepsy or seizure disorders. That can occur anytime there's any sort of abnormality in the nervous system, okay? Gastrointestinal tract impairments, I don't think I need to tell you all about that, and congenital heart disease. I put the asterisks on these 3, language, GI, and congenital heart disease, because these are ones that research has proven that with improved activity, i.e. physical activity or physical therapy, we see promotion of the function of those systems, okay? So your speechies or your speech language pathologist will tell you if you go to PT and you can promote a stronger core, they're gonna have better vocalization and speech production, all right? With the GI tract, we can improve motility, we can improve contractility, we can also help to relax by changing the way we're positioned, okay? And then also improving muscle tone in general. Our intestines are lined with muscle, smooth muscle tissue. So we can still affect change there. And then congenital heart disease, just by the sheer activity of getting some cardio in, we can help to decrease the risks and secondary effects of that. So physical therapy, you guys, most of you said that you've been there, done that. What should it be happening? I'm talking to you now as the neurotherapist. So in a child who has an abnormal nervous system, what should be looking at, okay? What should be on the docket? The therapist should be looking for hyper or hypomobility. In children with Mowat-Wilson syndrome, what we're finding is that primarily we're worried about tightness at the hips, hip tightness. And then the previous conversation with the group that was just in here before you, we talked a lot about ankle tone, high tone in the ankles and plantar flexion contractures. So that's another one. It's not popped up in the limited research yet. Hips is still the talk, but I think that we'll probably see that soon. Gross motor skill assessment. If you've ever heard of a Denver or a Peabody, those are the assessment tools that we use in therapy to look at those, okay? We should be looking for strength assessment. In the neuro exam, we're looking for reflexes, tone, and symmetry. Anybody know what tone is? Not really, right? So what tone is, we all have resting muscle tone. So the reason that you can sit in your chair and not completely fall over right now without having to think about it is your resting muscle tone. Kids who have Mowat-Wilson syndrome have hypotonia primarily or initially, okay? And so what that means is they don't have the resting muscle function or ability to keep an upright, erect posture all of the time, which is why you may see them sit and kind of relax. They're just very mellow and relaxed, right? It's not even a conscious decision. It's just that's their body's resting tone. It's hypo. It's less than normal, okay? And then as we start to see them move toward the walking phase, we start to see some of the hypertonicity occur, and that's when we end up needing Botox injections and night splints because the calves are getting very tight, okay? So too much or too little is not a good thing, and therapists can help to affect that, but we can also help to guide you in the right direction of managing it. Balance and postural control should be assessed, meaning can I maintain a static position? Can I move within a position dynamically without falling over? And then protective responses and righting reactions when they're age appropriate. So a newborn infant is going to have those yet, but as they age, we'll be looking for those. And then 2, your neurologic specialist should be privy to any imaging documents you've got, MRIs, CAT scans, because what we're trained to do is look at the brain and see abnormalities and identify, based on that abnormality, what is the functional impairment that will be present. So we know all the parts of the brain and what they're supposed to do. So if a part of it is abnormally developed, we will know how to plan for that in our treatment session, okay? And I think that's one of the things that a lot of people say, well, I didn't know a physical therapist did that. I thought they gave massages. We do a whole lot more. And you can just ask my husband, I don't give any massages. Observation of the child's spontaneous interaction with the environment and exploration of play, that's key, right? Kids don't like strangers, you've taught them well. And so we really just need to see what are they doing when no one's watching. And if we can't see that, then we need you to tell us and fill us in. So once we've done this individualized evaluation, the therapist is going to use all the findings to come up with a treatment plan. And the treatment plan should be based on your kid's needs. What are their impairments? All right? There's no magic formula for working with a kid who has Mowat-Wilson syndrome, or even a kid who just has hypotonia. They need to be looking at, from a movement analyst standpoint, where are the impairments and what can we change? They can also look at any kind of recommendations for equipment you might have. If you need a wheelchair, if you need any kind of assistive device for walking, or gait trainers, standers, your therapist should be a part of that conversation all of the time, okay? You want to be really aware of not getting your equipment from sales reps. It needs to be a conversation with a therapist and someone who's maybe got an ATP. John, for instance, out there has his ATP license, which is Advanced Technology Provider, which that person is taught to assess the person in the equipment rather than just selling the equipment. Home activity and exercise prescription is key. It does not matter what you do for those 45 minutes to an hour, 1 time or 2 times a week with the therapist. What matters is what you take home and do every day on a daily basis. They're also going to be able to provide you with reassurance on whether your child is meeting their motor milestones or whether or not it's possible to get there and where we need to go next. And they can give you a timeline on how long we think it'll take to get to that next milestone. They can educate you on the best ways to maximize their progress of motor development, meaning how can we make the most out of what we've got and keep things moving in a forward direction? How can we prevent regression? And then they can provide referral to an appropriate medical practitioner if necessary. By this I mean maybe it's time to go back to the neurologist. Maybe the tone has gotten to a point where it's not being managed and we need something else on board. Maybe we've noticed, wow, there's really been a lot of change in core stability. It'd be a great time to get speech back on board. We can really change something now. Or it could be the child that may need some bracing or some orthotic inserts. The therapist should be having the conversation with the orthotist of this is what it looks like when we walk or when we stand. This is the error, and this is what I want fixed. Then it's the orthotist's job to fit the child for the brace. It should never occur that the orthotist just gives the child the brace without the therapist having the conversation or seeing the child with the orthotist. Okay? That is a bad recipe for braces that don't fit well and don't really work. And inevitably will have you running back to the orthotist 2 to 3 times every time you get a new pair of braces. So what is treatment aimed at? Treatment's aimed at promoting the child's core strength. I've said that I think 3 times now already. It's really important. It's the basis of everything. We've got to have some core stability before we can even worry about moving. We're going to look at functional abilities and getting those motor milestones met. Specifically, we need to look at what is it that you want out of this. Okay, I think back to a discussion I had with a mother who brought a child in who was 16 and not putting on their own braces. I said, oh my goodness, we got to get this going. And she said, no. You don't need to focus there because I've got 4 other children and every time we leave the house, it's a fiasco to even think about having him get his shoes on. That's not where I want you to focus. I would have written that up as a goal because at 16, that would be age appropriate that someone of his ability could do. She didn't want to worry about that. And that's A-okay. I am working for her and him. So if that's not their goal, I shouldn't be focused on it. Move along. We've since had a conversation, and she's more willing now. All right. They also need to be play-based. What is a child's job until they're 18? To play. And then they can go work, right? And so they need to be playing, and we need to make sure that the therapeutic activity we're giving them is play. It can't be exercise. All right? They will see right through that. And they will say, no, thank you, I'm not doing that, in whatever method they choose. So the goals of the treatment should be to progress milestones, to increase independence or participation. Not every child will achieve independence in every activity, but we at least want to engage them as much as possible and allow them to participate so that they can have meaningful lives. We want improved postural control, muscle strength, balance, and coordination. That's a generic line. Every therapist wants that for every patient. Okay, that's just better everything. And an improved overall quality of life. So when should you seek PT? Well, the earlier the better is great, right? But maybe you didn't have access to it, or maybe you didn't know it was an option, or maybe you just didn't feel like it, or maybe you just got around to it. Well, the good news is, don't worry, you didn't miss the boat. So everything we have in research shows that the brain is malleable, the brain can be changed over time, and we've got this great thing called neuroplasticity. It's just a big fancy word for the brain can grow new connections, synaptic connections. We can have axonal sprouting, which is where we reach out and touch new places. And so that is how we train the brain to do things that it may not figure out on its own. So in a normal nervous system, we have discovery, and it's motivated by discovery and change, and so we seek that. But in an abnormal, we have to set up the environment and promote that change that we're looking for. It's still possible, it just takes a little extra work, okay? But you've got to know to do it. And as soon as the delay or the disability is identified, that's when you seek it, okay? And then along the continuum, anytime there's a change, whether it be a physical change, an emotional change, a weight change, an equipment change, an environmental change, a family change, those are all right times. There's really no wrong time. So what are the strategies for successful treatment? If you're already in therapy, I hope you look at this and say, yes, we already do all of that. If you're in therapy and you're not doing this, I would ask you to take this back to your therapist and say, hey, this is really good. We just got this at this conference. You want to do it this way? All right? They'll be receptive, and if they're not, maybe find a new therapist. So you want to persist with patients. The developmental, I apologize for the typo there, sequence should be followed. We want to promote symmetry and alignment, maximize active participation by the child in the task, reduce support and assistance gradually, keep the activities functionally based or play-based, and set up the environment for success. We're going to go through these now, and I'll explain what I mean by them. So in the presence of an abnormal motor system or abnormal motor responses, all the research shows it takes longer to make change, all right? And I can tell you this research is relatively dated now, but about 8 years ago, we kind of burst through somewhat of a ceiling and found out, okay, to make brain change for an upper extremity task takes 600 reps. Okay, I'm not telling you to go home and do 600 reps of everything, but what I'm saying is it takes a long time, all right? And so we have to be really aware as therapists that we don't ditch an exercise or ditch a treatment strategy just because it doesn't work the first few times. We need to do it, set it up. If it doesn't work, modify something, but don't abort task, and then stick with it. Do it until it bores you to death, and then do it a little bit longer. All right? That's what the nervous system needs in an abnormal setting to really create change and make it be lasting. All right? The developmental sequence should be followed. You may say, well, I don't really know what the developmental sequence is. I've listed these positions down at the bottom. Supine, prone, quadruped, tall kneeling. Supine is just laying flat on your back. Then it's moving over onto your tummy. Then it's going onto hands and knees, or that crawl position that you're familiar with. Then it goes into tall kneeling, or being up on 2 knees. Then into half kneeling, so supported on 1 knee. And seated and standing fall in there too. These things need to happen before someone can really worry about learning to walk. Okay? That's why it takes us a year in a normally developing nervous system to figure out how to walk. We have to do all of these things. All right? And the transitions between these positions are really important. So it's not just, can my child hold sitting or can my child hold tall kneeling? That's great, and that's a perfect place to start. But once they get that, they need to work on moving in and out of it. All right? That's probably the best therapeutic activity you can do. Work on moving in and out of these developmental sequences. I've included this image, which I realize is not too clear from where you're sitting right now. And these are just the normal or typical progression for motor milestones through the first year. I've included where the image is from, which is a website. And so I've included it also on the reference so that if you guys wanted to pull it up, you could pull it up more clearly. Promoting symmetry and alignment. This is the hallmark of neuro. This is the bread and butter. This is everything that's important. Core stability and this, okay? And basically, core stability and strength have to be progressed over a stable base of support. You cannot make progress if you don't have the stable base, all right? And the symmetry and alignment is key. So this is where I see most novice clinicians or clinicians who are not neurologically trained. This is where they say, oh, I think we've plateaued, we need to take a break. You haven't plateaued. Go back to this step. Do you have symmetry and alignment? Are you trying to strengthen and progress function over a stable base? If the answer is no, you haven't done the part you needed yet. This is what has to happen. Maximizing active participation. This is really trying to get the kid to do as much as they can of the task without over-fatiguing them, frustrating them, those types of things. The cues we provide affect the nervous system no matter what we do. So whether I touch you or say something, your nervous system is receptive and responding. And that's whether it's in a normal or abnormal, typical or atypical nervous system. So I need to be aware that every time I touch, where I touch, how I touch, the pressure with my touch affects the system. So we need to be realizing, am I trying to facilitate or inhibit? All right, and your therapist should be able to teach you all of those methods for facilitatory and inhibitory techniques. We use inhibitory to lower tone. In a low tone guy, we use, I think I may have said that wrong. We use facilitatory in low tone and inhibitory in high tone, okay? And then verbally too. If I'm loud and excited, I'm going to excite a nervous system. If I speak really slow and soft and don't overwhelm somebody, I can be really soothing and put you all to sleep, and that's because your nervous system is relaxing, okay? We're not gonna go to sleep today though. The goal is to provide the least input needed. And so verbally, as therapists, as parents, as humans, we always overdo it verbally. So everybody needs to pull back verbally. I continue to struggle this over a decade into practice. Manually, we want to start proximally and move distally. We've got a slide coming up on this. There it is. Overall, we want to reduce our support and assistance gradually. When we start treatment or when a child's really having a hard time holding a position or transitioning between positions, we want to be on the shoulders or the pelvis. We want to be proximal or close into midline. That's going to provide the most input to the nervous system. As the child starts to get it, we need to start backing off, okay? And backing off doesn't mean, look, Mom, no hands. Kids don't like that, and neither do the parents. We need to start moving our hands distally or away from midline toward the ankles and wrists. The activities need to be kept functionally based. And so what this means is if you guys want walking to get better, then eventually walking has to be practiced. If you want dressing to be better, dressing has to be practiced. If you want the child to be able to sit upright better, that's what has to be practiced in lots of different ways for a very long time. The therapist should discuss the daily needs with you guys. So they should say, what is it that you want us to work on? You should be the leader of this. They should be the director of how it happens, but you should be deciding what it is that's being worked on. Okay? And if you say, I just don't know even where to start, they should have plenty of ideas, but it really should be about what it is that you guys want help with at home. The children's main functional responsibility is play, so we need to find activities and interests that motivate them. If they're into Paw Patrol, then we need to be doing something with Paw Patrol. If they are into red balloons it is. We need to set up the environment for their success. And what I mean by this is, whether it's high tone, low tone, do we need the lights on, do we need the lights off? Do we need loud music, no music? Do we need extra stimulation or less? Also, though, we can break down parts. So we think of what is required for crawling, all right? Well, crawling requires someone move from prone into quadruped and then reciprocally move limbs. That's a lot to do. So maybe we practice just moving from prone to quadruped over and over and over and over until that part gets easy. The important part for neuroplasticity to occur, or that brain change that we're looking for to occur, is at the end of the practice, we have to put it back into the task. We have to put it back into the specific tasks that we were doing it for. If you don't close that loop, it doesn't get laid down and you don't have carryover. So whatever part you're practicing, that's great. I'm all about breaking it down, but you got to put it back together. And that means more than one time. So if you practice for 15 minutes on a part, the last 3 ought to be at least 3, if not 5, on putting it back into that hole. And be sure to provide adequate rest. We've talked about 600 reps of something. Well, that's ridiculous. No one has the energy or time for that. That's a research world. That's not reality. But if you are going to spend 15 minutes, know that they likely aren't going to have the stamina or the attention span for that. Attention span with age, some of these kids, we're talking like 30 seconds might be a good goal. And that's okay, but really be ready to allow breaks. And breaks are not just, I'm going to physically not let you do anything, but I'm going to talk to your mom the whole time. That's not a break. That's still stimulating. We talked about verbal cues, still stimulating the nervous system. If it's a break, everything's calm and quiet. There's no touch, there's no talk. So as a parent, what can you do for the child with Mowat-Wilson syndrome? Promote your child's development by talking and reading. That's not different from just normal parenting. However, because we've got this abnormal nervous system to start with, it may require a bit more demonstration and really showing them how to play with things appropriately. All right? Again, I talked earlier about how that nervous system that comes out normal to begin with seeks discovery. Okay? It's an innate function that we want to learn and do different things. But in that abnormal system, you won't have that internal drive for change necessarily. So we have to show. It's a lot more showing and doing and practicing and setting them up to be successful with toys and play. When it's appropriate, encourage your child to actively engage in all the ADLs, which are dressing, bathing, feeding, grooming, toileting. And this is hard as a parent, right? Because sometimes you're rushed or you're tired or bedtime just needs to happen because you're done for the day. But as much as you can make it therapeutic by having them engage in some way, shape, or form. If your child attends daycare or school of any sort, identify the tasks in the classroom that they're struggling with that you can help them with at home. not because you're trying to make it easier on the school, but so that your child can be more successful in that school or daycare-based environment. Follow through on the activities or exercise plans that your therapist has designed. However, be really honest with your therapist. If what they're telling you to do at home is not reasonable or is not something you're going to be able to do, let them know that ahead of time. They'll come up with a different plan. All right? And then seek referral for therapy services whenever you notice a change in function. All right? So whether the child is progressing, and that's great, it's time to monopolize, let's get in there and help, or whether they're starting to regress. All right? These are the references I used in making this presentation. And I will tell you, whatever therapists are out there seeing your kids, tell them to start writing these up in case reports, because there is nothing in the physical therapy literature recently, like within the last decade, that's really showing anything. Okay, we've got tons on hypotonia, but nothing specifically with Mowat-Wilson. So encourage your therapist to start writing this stuff up. They're going to be like, what? No. Some resources for you guys. If you're saying, well, I have a PT and I love them, or I'm looking for one, or I just want to Google them and see, Pediatric APTA is the Professional Association's pediatric resource for you. All right? Lots of stuff on hypotonia there for you. APTA.org is just the professional association in general for physical therapy. MyChildWithoutLimits.org is a site that I fell across when I was actually preparing this presentation, and I really liked a lot of the information they had on there. A lot of good examples of exercises you can do at home for low tone. And so I put that on here because I thought, gosh, if I were a parent, that would be a really nice place to start or continue. And then if you're thinking, well, I have a therapist and that's great, but my therapist is not a neurotherapist, so I wonder if it would be good to have my child looked at by a neurotherapist, you can actually go to Find a PT, which is at apta.org, Find a PT, and put in your zip code and look for someone who has that NCS, that board-certified specialization in neurologic physical therapy to help find, and they can work with your therapist. It doesn't have to be you have to break up with one and find another. They could do an eval and say, hey, this is where I'd be looking at, or hey, did you think of this? Because they're certainly going to be movement analysis focused rather than just impairment focused. Okay? And if you could find a PCS NCS, well, you've hit the jackpot. Because the PCS is just a pediatric specialist. I think there probably are, 1,200 of in the nation. And the NCS, there's probably 900. So it's not like they're everywhere out there. And you don't have to find someone with this specialization. But if you're looking for these types of activities and you're wanting it followed by this and you're really wanting to promote as much as you can for the nervous system, these individuals have demonstrated that they've sought extra and they've proven themselves to really understand the neurologic system and all the ways that we can help to affect change for it. All right? So with that, I want to open it up to you guys because I'm sure you came with your own questions and I couldn't have covered everything. So what do you have for me?